Good day, all, and welcome to the Teledigm Pulse podcast, your Rural Health Matters resource. Hear from your colleagues and industry experts on rural health issues and innovative care models that make a difference for rural hospitals, providers, and communities. Shane Fleming, co-founder, CDO, Teledigm Health, and excited today for our Teledigm Pulse podcast, welcoming Dr. Renuga Vivekanandan and Dr. John Horne, infectious disease physicians, and our infectious disease team lead for our ID-driven antimicrobial stewardship program. And it's been a phenomenal program, and I am excited to share their message with our listeners today. And it's an amazing program, and I'm honored that the two of you have taken time out. Not only taken time out of your day, but you're here live in person. I shouldn't say live. I guess this is being recorded, but you're here in person in studio. A fancy studio it is for sure, but nonetheless, it is. I'm honored that you're both here, and just blessed that you're part of our team and the amazing work that you've been able to provide our rural hospitals over the last, 7-8 years already. It's unbelievable it's been that long. But let's just take a few minutes, and I'd like to have you both introduce yourselves and a little bit of background about yourselves, and the listeners prepare yourselves, because this is going to be a great show, and I'm excited. So,
yeah, thank you, Shane. I'm excited to be here. I'm an infectious disease physician by background. I work in academic health system center. I'm a infectious disease physician with lots of teaching experience and research, but my passion is antibiotic stewardship and how to make sure we use the right antibiotics for the right patients, for the right community at the right time. So excited to share our experience and our journey with you today.
Excellent. Honored to have you. Dr. Horne?
Yes, thank you so much for having us. I'm also an academic infectious disease physician, and, we've been working with lots of hospitals. We've been working with lots of critical access hospitals and large hospitals doing our antimicrobial stewardship program, and it's just absolutely fantastic. It's been going so well. We get so much great feedback from the hospitals. Whenever we call and talk with people, they start out by thanking us usually, and, they're so appreciative. But we're really glad to be here.
Excellent. Well, I can assure you that the hospitals are thankful for your service and appreciative. In fact, we have dozens of service lines, but our stewardship program has never been shut off ever. It's 100% retention rate over the last 7-8 years. It's an amazing program. And I think I'll go back to when we first met, and I remember it was at a hospital association conference in Nebraska, and I ran into the two of you. You had a little booth there, your MDstewardship booth on the side, and I just walked over and I said, "What are you guys up to? Tell me about what you're doing, and tell me about what is antimicrobial stewardship back then." I didn't even know what that really was, to be honest with you, and getting a chance to meet you, John, and you, Renuga, was an enlightening thing, and I just got, this is amazing what you guys are doing. More in the larger systems, in bricks and mortar buildings, but golly, this could really benefit rural hospitals in a big, big way. Plus, that was on the heels of the regulations changing and the requirements changing as part of the conditions of participation and regulatory environment, as well as the Joint Commission was involved in that. But nonetheless, it was an important program, and we were just honored that you wanted to team up on this and offer this to the rural communities, because it's been a major issue. The other part of that, as part of a tertiary system analysis, one of the things we found was infectious disease consults that were requested upon arrival, essentially, or part of the transfer process where patients were being transferred into the tertiary center for ID consult, and hospitals would admit them, the ID physician would go in and see them, do their thing, and then the hospital, as the course of care, could have easily been done wherever that patient came from. And part of that strategy and discussion was around, golly, if you have an ID physician involved in your stewardship program, would that make a difference? And would that help mitigate some of these ID transfers? And in fact, it has, big time. It's really been a powerful program. And one of the things we also learned as part of that process was having an ID physician involved in your stewardship program is paramount. And the infrequency, or I shouldn't say the infrequency, but the lack of availability of ID specialty in general is so limited that it's a tough proposition. So it's been an amazing program. So I think when I reference program, the question is, what is a program? What is a comprehensive program? So I thought we'd start with you, John, maybe elaborating a little bit on when you think of comprehensive stewardship programs, what do you think? What do you think about it?
And antimicrobial stewardship. So it's kind of a big phrase, but it essentially just means using antibiotics correctly. And so a lot of antibiotics are given, either incorrectly or they're not needed in the first place. And so that's really what the program helps with. And antimicrobial stewardship programs in hospitals are essentially trying to use antibiotics appropriately within hospitals. That's what the goal of the program is for, really to get the good parts of antibiotics, so the benefits of antibiotics, and then minimize the downsides of antibiotics. And, when we started practicing, we were getting calls from these small, like rural hospitals, critical access hospitals, and they would essentially call us and ask us for help. And so, we would help them with the antibiotics, their antibiotic questions. So they may call us and they'll say, I'm seeing a patient and they may be growing something in culture. They may have identified an organism, or they may say this patient has a penicillin allergy. What should the next antibiotic be as far as if I can't use penicillins? And, we were getting some of these calls and we kind of looked at it and then said, we should have an organized program to help these rural hospitals that don't have access to infectious disease specialists. So, if we're kind of talking, we said, if my family member were in a small hospital and they were getting antibiotics, we would hope that they would be talking to an infectious disease physician. And, we met you, Shane, at that conference, and, that's when really things came together and we were able to put together a program. As far as a comprehensive antimicrobial stewardship program, there are 7 core elements that are required to have a complete program. And, these elements are put forth by the CDC. And so they have the 7 core elements. And so we go one by one with the hospitals we work with and make sure that we're completing each one. And, and that's just, as a foundation, as a basics, we go far beyond that. But really we help with any antimicrobial stewardship questions or infection questions that hospitals have. And we're available. We speak daily with the pharmacist on site, and the pharmacist will go through the patients on antibiotics, and if there are any questions about which antibiotics or is this the appropriate antibiotic? Do they need an antibiotic? Is it the correct dose, duration? And we kind of go through that with each patient, and we're available for the hospitalists or whoever the clinician is that's seeing the patient at all times. So they can call us at all times and call us and just essentially say, this is the patient I have, and we discuss the proper use of antibiotics.
And we have a fancy name. It's called prospective audit, but basically it means it's like talking to the pharmacist on site and helping them with whatever the questions that they have to treat the patient.
Sure. Yeah, audit's kind of a dirty word.
Yeah.
That audit. We try to leave the audit word out in the woods somewhere. But a couple of things on that. Number one, it is comprehensive and it exceeds all the requirements. And having access to an ID physician is a huge value add to that program. It's been proven time and time again. I want to emphasize, though, that the prospective audit or the assistance with that, it's a collaborative one. It's not a punitive one. And oftentimes when people hear words like audit and we're reviewing patients, they sort of gravitate to this. Oh my gosh, I have ID physicians.
Policing, right? They also think of that term, but it's really collaborative, being an extra resource for the bedside provider, and just really talking to the pharmacist on site and talking about those difficult cases, and then reaching out to the primary care provider, and then how do we all collaborate together. And having an infectious disease physician, we have a different lens on the infections that patients have. Shorter course is better sometimes. A lot of things have changed in medicine. Now for pneumonia, you could treat them for like 5 days and it should be enough. But so working on those shorter, better evidence-based practice really helps our patients.
Yeah, our whole goal is to act as a resource and support the clinician and provide support for these hospitals. if they don't have access to specialists, they're doing the best they can. And sometimes we'll look at it and just say, those are the correct antibiotics, and it really helps peace of mind for the clinician.
And with that, one of our passion and my passion too is like, how do we help our rural communities? When you look at Nebraska, for example, all the infectious disease physicians majorly are in the urban area. Mm-hmm. And we don't have enough infectious disease physicians in the rural communities. And we have to give equal care, equitable care. And this is a really nice way of being able to reach into our rural communities, being able to work with our rural hospitals and provide those evidence-based care that our patients need.
Sure. I can't emphasize enough obviously rural health inequities is a major target and mission of ours anyway, and it's been a huge help on that front. But I do want to emphasize too, though, that we have referenced a lot of critical access hospitals or small rural hospitals, but what we found was, there's large hospitals that need the same stuff, right?
Exactly.
So, you do work with a lot of large hospitals, 500-plus bed hospitals that are part of the program. So really, if you look at the stewardship program strategy, it's really hospitals of 10 beds all the way up to 300 to 500 beds and everything in between. And the needs are different.
Yes.
Based on, the size, based on their payment structure and their strategy and their goals, of course. But nonetheless, it's a huge need, primarily from what you just said, that the ID physicians they're few and far between. Maybe you could speak a little bit to, in those larger hospitals, they may have ID there. They may have, but let's say it's a 300-bed facility, a busy place. They're carrying a census of 200 patients or whether it's 100, 200, 250, whatever, somewhere more than 5. And you have an ID physician that's maybe doing some boots-on-the-ground activity, but then they're busy in an outpatient clinic. Do they really have time to spend in getting into the weeds on a stewardship program? Could you maybe speak to that a little bit?
Yeah, that's a really good question. Personally, myself working in an academic center, large hospital, where we have many infectious disease physicians, but they're really busy on the day-to-day taking care of the patients, in the inpatient and the ICU where they have census of 20, 40 patients. So it's really hard, even if you have an infectious disease physician seeing patients, to be able to give time to do antimicrobial stewardship. Antimicrobial stewardship is completely different, where you have to monitor the antibiotic use across the system in the hospital. Who's getting what are the cultures, what are the blood cultures going positive. So it's very complicated compared to when you see patients on a day-to-day basis. So you really need the dedicated time of an infectious disease physician and time from the pharmacist. And the CDC and CMS, they all recognize this. And that's one of the big push to have dedicated time and being able to do this work as well. So it's really, you have to have a comprehensive plan. You have to have time that is from a physician, ID physician, and a pharmacist to do this work.
Sure. Well, I completely agree, and it's definitely, even in those larger facilities, has made significant strides. We'll talk a little bit about that here in a minute.
Oh, and you mentioned their goals, and whenever we start working with a hospital, up front we'll ask them, what are some of your goals or challenges that you have? And sometimes hospitals, they're a little nervous to tell us, they have a problem with C. diff or they have a problem with, readmission with infections. But oftentimes a lot of the hospitals have the same problems and the same questions. So we'll start with, one of the things, the core elements is to have interventions. And so we'll ask them, what are some of the key issues that you want to focus on when we first start with them? And, if they say, C. diff has been a real problem, we'll start with whatever they want to start with and make some progress on those fronts before expanding to other areas. And the program has really done a great job with all the hospitals we've worked with.
Yeah. We got countless campaign examples. We'll share a couple of those in terms of success stories on that front. You mentioned the requirements and part of the core elements. Can you maybe speak to some of the requirements, maybe some of the newer requirements that have come around? I know that when we first put the program together, there were requirements that were released. When we work with many hospitals in many different states, and many of them had stewardship programs when we started this program, and they're different. Not all stewardship programs are created equal. Most hospitals claim they have one. I would suggest most of those were sort of just pencil whipping. And there are others that were in pretty good shape, but most of them were really lacking a lot of depth to the program. Do you see anything coming down the pipe in terms of requirements that are a little different than maybe what's in the past? I do know that things coming from the CDC and the governing bodies and the Joint Commission prior to the pandemic were focused on, if you recall, the shift was more, okay, yeah, here are the requirements, and yeah, people can do those, but now we're going to shift the focus to quality. Yeah. Is your stewardship program providing quality results? Then the pandemic hit, and they just kind of sat on the table. And now we're starting to see a reemergence of that push towards more quality stewardship programs. What are your thoughts on that?
Yeah, I think that's a really good point. And one of the big area of focus has been about education of the clinicians and the frontline healthcare workers. And that is really important. As much as we're doing, prospective audit and feedback, it's really important to keep everybody up to date on the evidence-based practice and continuous education on why we do the things we do and what we all need to do together. As far as MD Stewardship, Dr. Horne has really led a amazing webinar monthly on teaching different topics for our hospital system, where they learn about, C. diff and isolation practices. Those are very key, but it's really important to keep up to date and make sure everybody is learning those tools. And what Dr. Horne has developed, it's really been great. It's not only for the physicians or advanced practice provider. Anybody can learn from those content. Our nursing staff, our EVS staff, our infection preventionists. So these are really great tools for anybody in the healthcare system to learn.
Yeah, and that webinar has really gone very well. So all the hospitals that we work with, they have the opportunity, and anyone in the hospital and in any area of the hospital can access our webinar and call in and essentially watch as we give a presentation. And we'll give a presentation on a topic that has been requested from one of the hospitals. And it's really good to give a foundation and give a short talk on a subject and get everybody kind of on the same page when it comes to the goals of some different areas and treatment. Whether that's we'll give a webinar on influenza during influenza season, wound care, pneumonia, and kind of just go through and talk about the basics and the goals and some of the challenges that some of the hospitals have. But yeah, it's gone extremely well.
And not only that, the attendance in those webinars is off the charts. There's a lot of people that attend. And the other part of that too, that I really appreciate about your team is that you're always looking for feedback in terms of what should we talk about.
Yes.
What would be helpful. What are the frontline folks needing help with? We've had all kinds of requests for various things over the years, but you've always been very accommodating.
Yeah, and I think that's really important because sometimes we might not know what they need in the front line, so its feedback is really important. So we're teaching what they need in their frontline healthcare setting.
And we're used to teaching and getting questions. So we teach with medical students, medical residents, infectious disease fellows, and so we're used to getting questions, and we're happy to answer any questions and send where we got our information from. But we appreciate that people won't want to call if we're not friendly and happy. So yeah, and when we start with places, they'll we love to give out our the information from the hospitals that we work with, as far as if they'd like to call and see about the program, how well it's been working in some of the hospitals that we work with. And their big question is, are they friendly? Yeah. Are they nice?
Yeah.
Because the concern is that they'll call us and they're kind of nervous that they may not know some of the basics, but or they know a lot and they just need a little bit more information, because some of the guidelines are quite difficult to kind of go through sometimes. There's so much involved, and a lot of people when they put together their information for their hospital as far as their algorithms for which antibiotics to use, they don't have any help. And so we want to provide them with, any help that they need. And we're happy to, send our references, send articles, send things, and stay up to date with the newest information.
And I want to add to that, when we interact with folks, we're very kind, and I think it's really important in that when you're taking care of a patient, being kind and listening. And so we use all those tools to make sure that we're giving the best care for the patient and giving the best tool for the providers at bedside.
And, when we speak with the pharmacist on site, they may identify a patient that's on, multiple antibiotics, and we'll give the clinician a call and just say, hey, I'm just calling to see if I can help, see what we can help with the antibiotics. And when we first start calling, if they're not familiar with the program, they might think, oh, am I in trouble? Did I give something wrong? Or they might think that we're going to restrict antibiotics, and that's really not what we do. We don't restrict, and we don't ever say, you're giving the wrong thing, because we're not seeing the patient. And so it's really up to the treating clinician what they want to give, but we want to provide support and help with anything that we can help with.
Yeah, that I can't agree more. These are some of those programs, really regardless of any virtual strategy or program. Sometimes you have just some ambivalence on how this is going to go, and so you get some turf issues. But in the end of the day, you break those down with being collaborative and being relationship building, and to your point earlier, being nice. Yes. And I can't think of anybody that knows you that gets a call from Dr. Horne is not shaking in their boots. This guy's here to help me.
Well,
so
after starting with a program, they'll it's really nice to see that they'll say, oh, whatever you recommend, and things like that really shows kind of the relationship we have with some of the clinicians that we work with.
Sure. And not only the clinicians and their receptiveness to the program, which is always important, and it's how you guys build those relationships, what really wins the day. And then that sort of opens the doors into some of those more sensitive areas that you described, because in most cases, and it's kind of funny because you're talking with some hospitals. I was just with one here a couple of weeks ago and talking about their I think this program could really help. We could build a couple of campaigns around these issues, particularly with CAUTI and CLABSI. And they go, well, we really don't have an issue? I go, well, the data here suggests otherwise. Yeah. And by the way, anybody can access it.
That's right. Yeah.
And so it's a matter of on building strategies around that. And I'll give an example of one of the larger hospitals. So this is a 350 bed facility. And when we first got involved, in the deep dive, when we start those programs, if you recall, they were having a significant issue with C. difficile.
Yes.
And they had a strong stewardship program in place, or at least they thought it was strong. They were trying, let's put it that way. And they were. I mean, they had a lot of stuff in place. And then they really had a significant infection control team that was really working on this C. difficile issue over a 2.5-3 year period. And the campaign was then built on trying to strategize, okay, what's really going on? What's the root cause of the C. difficile issue? Maybe you could speak a little bit to that campaign and strategy.
So I think when we started with that campaign, and personal experience in other hospitals too, we call it diagnostic stewardship. So it ties really nicely with antimicrobial stewardship. How to test for C. diff. Do we have the right testing? Are we unnecessarily testing? Sometimes we're testing patients too late. So they came in with C. diff, but the hospital tested it too late. So now it becomes hospital acquired, which ends up resulting sometimes up to $35,000 in loss per patient, significant dollars through CMS. So we did the campaign, and from my experience, and they had significant reduction in less than a year, and they were able to show cost savings and good patient outcome. So, antimicrobial stewardship, the programs that we have, not only does it do antimicrobial stewardship, but we do diagnostic stewardship, which really helps with like CAUTIs, CLABSIs, C. diff. For example, I could tell you about, Foley catheter-associated UTI, right? We all know urine culture gets ordered so many times. So we have worked with hospitals. When we looked at it, they were doing urine culture because it smelled bad, it looked bad, and those are not real indications for ordering urine culture. So really teaching, everybody about when to get a urine culture, also working with microbiology to say, well, you don't need a urine culture for looking bad or smelling bad, only when there's more than 10 white cells, for example. So really doing those campaigns, not only did it help reduction in antimicrobial use and appropriate care, but also helps with hospital-acquired infections. And those have significant impact on hospital systems and on, of course, patient care as well. So we were able to do bloodstream infection, Foley catheter infection, C. diff infection, MRSA infection campaigns to help through our antimicrobial stewardship program.
Absolutely, it's been an amazing program on that front in terms of the diagnostics, and I want to emphasize. I think for a lot of facilities, particularly the larger facilities, this is a missed opportunity in many facilities.
Oh yes.
And they're hemorrhaging dollars on these issues and don't even know it.
Just for our audience right now, for central line bloodstream $75,000 per patient if you have a case. C. diff, $35,000. CAUTI up to $45,000. These are direct and indirect costs. So it can rapidly add up, and those dollars can be saved and used for other resources in the healthcare setting. So it's really important not to get these infections in the hospitals.
Right, and I think we all know, given the current economic environment, it to just throw dollars away at that is not ideal for certain. Yeah, and I think, back to your CLABSIs, we worked with a hospital on that front too in a campaign where the best prevention of CLABSIs is just not to put the line in the first place, right?
Exactly.
And so this is about a 200-bed facility that we were working with where really and this came down to unnecessary central line placement and PICC line placement. Yes. Where they had a lot of challenges with central line infections, and we found that there was a lot of PICC lines that were unnecessary that were being placed. Exactly. And the downstream, and oftentimes what's missed in that is not only the potential. Obviously, if they don't have a central line, it's hard to get a central line infection. Number one, yes. So that's easy to avoid that. But the cost of the insertion and then the downstream impact while these patients were sent home with unnecessary antibiotics at home that just didn't need to be there. So it was a significant impact and a lot of central lines that were avoided as part of that strategy.
Central lines avoided, PICC lines avoided, and you could really, like Dr. Horne always says, a lot of these infections, he's able to take care of them, and through MD stewardship programs, oral antibiotics. Would you say that?
Yeah, all the studies, more and more, there are so many studies that are showing that pills are very effective, and you can treat a lot of infections, like even osteomyelitis, even bone infections, you can treat with pills very effectively. And once we work with a hospital for a while, they kind of see that, and you can see the shift is more towards pills and not putting in PICC lines, not putting in mid lines, which is great for the patient.
Yeah. It's definitely a lost opportunity across a lot of facilities. And this kind of gets back to, in those larger facilities, a stewardship program that has the time and the capability, the wherewithal to really do diagnostic stewardship on top of it. Most people just don't have the time. Or the people that do have the time don't have the resources or the knowledge base to really effectively get to the root cause of it. So let's shift a little bit. We've talked a lot about the HAI components. What about the microbiology strategy and, working with the lab and strategizing? You mentioned, Renuga, you mentioned the picking off the order in the UA to begin with, yes, or the culture to begin with. But what happens when those specimens get to the lab? How can there be improvements made on that front?
Yeah, that's a good question. So, if we're able to get a good culture, whether it's a blood culture or a urine culture, if they grow an organism, they'll be able to test which antibiotics work, and they give a report, and that's called a susceptibility report. And, how that is shown and how that's kind of interpreted and, some of the specifics of that we can really help with. So, if there's an antibiotic that works, sometimes you can kind of show a cascading approach to the susceptibility report for which antibiotics would be the best ones to use for that situation. And so we can help with that. There are other reports like antibiograms that, that we help with, but also, it's really our team. We have clinically trained antimicrobial stewardship pharmacists, and they will help create, the antibiograms with some of the hospitals that we work with, and look it over and kind of, be an additional resource to give feedback on how it should be shown, and just small changes can make a big difference for about the number of antibiotics and which antibiotics are given in the hospital.
And I always think of it as when you show antibiotics, you have the Ford type of antibiotic,
that's a good,
and you have the Cadillacs type of antibiotic,
yes,
or the Tesla. But if 4 works just as well, you don't need to use the expensive kind. So what we make sure is we don't show that, to, kind of hide that, and only release it when you need it. So again, you're using the narrow spectrum, the cheapest antibiotic that works just as good and causes less harm to the patients.
Yeah, sometimes the older antibiotics work better than some of the newer ones.
Exactly.
And they're cheaper, and you don't have to give them as many times, during the day, and that's a really good way of looking
and
at it.
some of these new antibiotics, people will be shocked to know they can be like up to $2,000 a day.
Oh, yeah.
Versus the old antibiotics, it's like $20 per day. So really making sure that we're wise with our dollars and resources, and the patients are getting the best care that they need.
Sure.
Yeah.
Sure. Well, hopefully there's no Ford representatives listening to the podcast today.
I really like Ford.
I have one. So.
I have one.
Yeah. So at any rate, no, that's good. And I think beyond that, the lab is another area that's oftentimes underrepresented in terms of stewardship strategy. And in addition to that, and I'll give you an example. Especially in some of the larger facilities, you do run into a fair amount that have biofire, for example. And I'll give one example on this. But what we found in a lot of these facilities that have biofire is they maybe have it, but it's sort of like having this fancy machine that maybe they don't know how to leverage it exactly the very best way possible. And which is unfortunate that if they have the technology there and they really don't know how to leverage that technology, it's a big deal. And to have your team available to really help them sort of hone that process, and whether it's a biofire response team on blood cultures and how to do that, what to look for, how to strategize it, how to develop policies and procedures around that. And then there's something as simple as the hospital we were working with here just a couple of months ago, which is a 200-bed facility that had biofire, but they had a lot of outpatient activity, and physicians across the community were just ordering these comprehensive respiratory biofire panels at roughly $1,000 a pop. And I think the question that was posed to us as we got involved in that strategy was, by and large, the lab knew they really didn't need to make those orders. The chief quality officer really knew they didn't need to have those orders. Why were they ordering those? Do they really need that even available? But they had pushback from the medical staff and maybe had trouble articulating why, the why behind the, we really don't need to be doing this, folks. These tests work just fine, way, way, way less expensive. And so it's helpful to engage the MD Stewardship team on that strategy because, have an ID involved in that, and ID to talk to the medical staff and offer them latest best practices and maybe why that comprehensive biofire panel is not necessary. And the results are impressive on that front. To not only turn that around, they get rid of that test, and then they're implementing a blood culture strategy around biofire. And in the end, they're going to have an improvement in their lengths of stay related to leveraging that technology, a much lower cost on the outpatient side, and collectively a significant financial impact. Maybe you could explain a little bit more about just the impact you're seeing in working with the microbiology folks.
Yeah, I'll take on the biofire, for example, like you were saying about the example of the respiratory pathogen screen. It's a great tool for research. It has like 20 different viruses and bacteria, but honestly, you don't need that in real life to take care of a patient. And it was $1,500 versus coming up with just a 4-plex molecular test. It picks up pneumonia, RSV, and COVID that we struggle in the wintertime, which is like $100-some, right? So now huge difference in cost, but you get the same answer that you want because other viruses, you're not going to do anything with them anyways. It's just you get better with symptoms care. So working on the microbiology with giving them those tools and making sure we use the right test at the right time, we were able to save dollars, but also improve patient care. So I think that has significant impact. But Dr. Horne, do you want to share other examples, especially like the urine culture one?
Well, we have had some patients in the outpatient setting have been getting PCR tests of their wounds.
Yes.
And, that hasn't been shown to be helpful, and PCR tests are very expensive. So, we'll get a call and they'll say, we did a PCR test and it had, and some of the PCR tests pick up very strange organisms that we don't usually see that are probably not clinically significant. So it means they're probably not causing the infection. And doing that, doing that expensive test and picking up organisms that aren't useful or aren't helpful to the patient's care, those are the kind of things that we want to try to cut back on and try to help with.
And that test, for example, might cost $500, but if we saw the patient, we would have said, oh, well, let's use doxycycline and augmentin, which is like $4 and $10 drugs, and that would have just as much help heal the wound with the culture versus getting this fancy test. So like really making sure we have the right test in the microbiology is important, and utilizing for the right time is important.
And so sometimes these hospitals, they'll contact us and they'll say, we're thinking about getting this machine, this PCR machine. What are your thoughts about that? Or we're thinking about, should we bring this antibiotic to our formulary and start using it? And, we're happy to have those conversations and talk about other hospitals that have done similar things or what our experience has been with that.
That's a huge value add to bring that level of experience to the table when they're pondering those types of, for example, we had a hospital that was pondering bringing in another biofire adjunct test and basically based after the conversation, we really don't need that test, so we don't need to order it and either have it expire or be used unnecessarily. So it's definitely helpful, and that kind of coincides with your point earlier about different types of lab tests and what's important, as well as comparing the antibiogram or the regional antibiogram to the current formulary. And similar, Dr. Horne, you've had questions around, should we order this test or should we have this test? Should we do this PCR machine? Should we order this antibiotic or should we have this antiviral strategy or antifungal strategy in the formulary?
And it can make a big difference, especially if we work on like sepsis protocols, because just changing the sepsis protocol can make a big difference for all the sepsis patients that come in. And some of the hospitals, they'll say, our sepsis protocol is about 10 to 15 years old. Can you help us update it? And we're
That's
happy.
It? Just 10 to 15 years.
So we're happy to look it over and share what we do in our practice and what we find helpful and any kind of those order sets, the pneumonia order sets, the urinary tract infections, all of these things that changing a protocol can really make a big difference for an organization.
Yeah, absolutely. And I know that there's been several examples of reduction in overall formulary spend as a result of having the appropriate and less costly antibiotic strategy as part of the formulary.
Yeah, working with the pharmacy team is really important, and then P&T committee, and really just restricting or formulary antimicrobials when you're really not needed. Like the example earlier, if you could use an antibiotic that is $10, Narrow works just as well, and bringing in a $2,000 a day antibiotics is very unnecessary. So just making sure we are using the right antibiotics on our formulary can help the patient and also save dollars as well.
Yeah, if the pharmacy if they're bringing in antibiotics that aren't used, at a certain point they have to throw those away and lose that money.
Yes.
So if they can prevent buying it in the first place, or if another antibiotic can be used in its place, those are the kind of things we can help with.
Sure. Well, I think the program that you've been able to put together and the resource that you've been able to provide rural hospitals, both large and small, and even in some urban areas, has been a testament to your team and to your passion around antimicrobial stewardship, which is, by the way, that's a hard find. It's hard to find an ID physician who's really passionate about antimicrobial stewardship. It's a tough find, and it's I think one reason why this program's been so successful, and it's a reason and a testament to all the successes that you've had in all these various campaigns and transfer prevention. And it's just countless. I could go on and on. So again, the work that you're doing in the rural markets is impressive, and it is recognized by many that they don't know what they'd do without you. So on their behalf, I would like to very much thank you for everything that you do and your program and the patients out there, thousands and thousands of lives that you've touched in the rural markets, providing better clinical and quality outcomes. So can't emphasize enough how appreciative I am that you, number one, you've taken time out of your day to come sit and talk with me, that's hard to. We don't have to pay you. Well, a cup of coffee, maybe. But at any rate, can't thank you enough for spending time with us today on the Teledigm Pulse podcast, and excited for this to be released and get your information out to people. Any final thoughts?
Well, thank you for having us today. Thank you for having me today, and I am also very passionate, and like working in antimicrobial stewardship like really reflects on my core value of helping others and the rural community and any of the healthcare system. So I am excited to continue this journey of helping others.
Yeah. Yes, it's really been fantastic. Thank you so much for having us.
We would like to thank you for joining us today. Our promise to you, the listener, you will be inspired or at a minimum find value in the information shared in this podcast. Please offer a comment or offer feedback so that we can improve this podcast and better meet your needs. Please remember to share this podcast with others that you feel may get value out of this by listening. And it's always helpful to subscribe to the podcast channel so that you're aware of future episodes and releases. In addition, if there is a rural health topic you would like to have covered on this podcast, please leave us a comment, or you can send an email to pulse@teledigmhealth.com. That's pulse@teledigmhealth.com. For more information or general inquiries, please visit teledigmhealth.com.